I'm very, very passionate about advocating for hospice and educating on the end of life. It's my area of expertise. I'm literally a subject matter expert by virtue of being a certified hospice nurse. We're dealing with people at what is arguably the worst time in their life, but it's also the most sacred. Death is really unique to the person who's dying. There is a feeling when a person dies, something in the room energetically. There's a shift that you can sense. I don't see it or hear it. I just feel it. Like there's just something different in the room. Their good outcome is for that person to live. Our good outcome is for the person to die comfortably. Hospice doesn't add more days to your life. It adds more life to your days. Because I've had patients who came onto hospice who didn't know that they were dying. I don't like euphemisms. I don't like to say passed away, gone to heaven. I've seen how confusing that can be for people. We use the words death, dying, died. I prefer now to just live my life and not worry about death and dying. So in a way, working with people who were dying taught me more about living.
You go by Hospice Nurse Penny.
Yeah.
And I didn't realize when I saw an article about you on the Daily Mail, and I was fascinated. I'm interested in the topic of death and dying, of course. I think most people are. It feels like you either avoid the topic or you're fascinated by it. It's kind of one or the other.
Yeah, you're all in or you're all out.
Exactly. But it seems like something we should be talking about as a society. But oftentimes I feel like people avoid it, and whether that's due to fear or just.
I think it's fear.
Yeah.
It's fear because it's unknown. We used to die in our homes with our family back in the old days, and then medical technology advanced to the point where we could keep people alive longer, albeit most of the time they were in the hospital living longer. And then when they died, they were in the hospital. So we weren't really around death as much anymore. And it became more unknown to us. We also have a medical community that is taught how to cure people, how to make people live. So when they die, death is seen as a failure. So there's, many different aspects to why we're kind of afraid of death. But what I've learned being a hospice nurse and watching thousands of people dying and how they interact with their families and how you can have a good death experience or a bad death experience is that the best way to have the good death experience is to be able to talk about it, to acknowledge it, to know what's happening. People are afraid when they see somebody going through the dying process. They've never seen it depicted on television or movies unless it's a violent death. They're great at making violent death look realistic, but not so much a natural death, which is how most people are going to die. So when they see their person going through these changes, their body going through these changes, it's scary to them. But as a hospice nurse, when I tell them that's normal, their relief is palpable. It's like, oh, it is? Yeah, that's normal. We see that all the time.
And how many, if you had to guess, how many deaths do you think that you've actively observed?
Oh, hundreds, maybe into 1,000.
Yeah.
I worked in two different hospice care centers for 7 years. That was the first part of my hospice career. So at the bedside, in your face, death and dying. Hospice care centers are mostly for people on hospice who have acute symptom management needs that cannot be treated at home. They need to have skilled nursing 24/7. And although the plan is to bring them in on this higher level of care, get them on the medications they need to be on, stabilize them, and send them back home, most people, when they have a pain crisis or terminal agitation, something that lands them in the care center, are close to the end of life. Those things happen close to the end of life. So they usually would die in the care center.
Gotcha.
So I might see 5 or 6 people die in a couple of days. I could be off on the weekend and come back to our 20-bed facility and we have a whole new round of patients. Everybody died over the weekend. So it's hard for me to estimate exactly how many I've witnessed their last breath, but it's it's been in the hundreds for sure.
Yeah, gotcha. And how many years have you been a hospice nurse?
20 years.
20 years.
Yeah. And I did patient care for the majority of that time. I also have worked in education, regulatory, and quality. I've always been the kind of person that wants to learn as much as I can about whatever I'm doing, whether that's being a bartender, or a ice skating attendant or a hospice nurse. And I was ready to leave the bedside, not because of the work itself. I love working with dying people and their families. There are challenges for sure, especially when you're a home hospice nurse and you're going into people's houses. I say being a home hospice nurse is like a box of chocolate. Going into someone's house, you never know what you're going to get. So it's challenging, but I loved it. I worked in the greater Seattle area and the traffic got to be so much I could not stand the commute anymore. And so I was just ready to kind of branch out and learn more. And I'm happy that I did, because now I'm really well-rounded when it comes to hospice. I don't just know about the death and dying journey and the grief journey. I also know about the regulations, the laws, the quality metrics, that type of thing.
So you've done the in-home thing, you've done the hospital thing, and so right now you're doing.
Right now I work 3 days a week. I'm a hospice quality assurance nurse. I was a hospice quality manager, but I'm on my way out the door. I'm getting ready to retire, and so I'm just doing some quality assurance stuff until June, and then after that, I actually plan on going back to work in a hospice, or not in a hospice, but for a hospice, doing visits. I live in a very rural county now, and it's sparsely populated. I've always thought it would be fun to do that kind of home hospice nursing where I'm driving, but I'm in the countryside. I'm not stuck in traffic jams, or cattle crossing the road,
Right.
So I do want to eventually go back to just doing kind of what we call per diem nursing. It's as needed. So if somebody needs me to go out in the middle of the night, then I would do that.
You love your job?
I love hospice nursing. Yes. Not necessarily quality assurance. I did love it. I was able to do a lot in terms of helping other colleagues of mine to learn about hospice. I did vigil volunteer training, so teaching our vigil volunteers what the dying process is like. So I've done many, many things as a quality nurse that I really loved, but I do miss the patient care. That's what I really love.
Does it take a special kind of a person to do that, to be there during the death and dying process?
I think so, yeah. It's not for everybody, but that could be said of any area of nursing. I would not want to be a pediatric nurse working with little kids. You think they're so cute, it'll be fun. But when I was doing my clinical rotation in nursing school, I had this adorable little toddler, and I needed to take her IV out. And I was like, oh, she's so cute. And I go to take her IV out, and she's screaming bloody murder. And I realized that I'm the devil to this child. She hates me,
Right,
So I think everybody has, a place in different areas of nursing. But I would say hospice, you can't be a shrinking violet. A lot of people have a different perception of what hospice nursing is. They love to refer to us as angels, which is just not true. They like to say it's a calling. I could kind of say it might be like that. For me, it kind of was. But, we have to be really strong. Like we have to be, we're dealing with people at what is arguably the worst time in their life. But it's also the most sacred. So we have to have the ability to have the wherewithal to endure the hard parts, but also recognize the really great parts, if that makes sense.
It does, for sure. Yeah. I was, just thinking about what you do, and and kind of thinking about like first responders and seeing them, come up to the scene of an accident and seeing someone dying, and thinking about just how much trauma those people, carry and take and hold with them, and my wife works at a place called Resilient Retreat. She's on the board of this place, and they deal with first responders a lot. And it's kind of like the process of helping them deal with the trauma that they endure as a part of their everyday jobs and life. And is that something, do you feel like trauma is a part of your experience as a hospice nurse?
I don't know if I would say that I have ever felt trauma, and I don't know that I would say my colleagues do either. the nurses that I've known that had trauma, that were experiencing trauma, didn't last in hospice. They left. I remember one distinctly that I worked with at the hospice care center who just cried all the time. And I just thought, why are you here if you hate it so much? Right. And she finally quit. And I saw her about a year later in the hospital, and she looked fantastic. And she was working in a dialysis department. And she said, I love it. It's the best job ever. I'm so happy that I did this. And I was like, yeah, okay. It's not for everybody. I think if it's too trauma causing, then you don't last. You burn out.
So is it, what is it? What's the difference then between you as a successful hospice nurse and somebody who fails and who carries that trauma? It's just, I guess, a lack of acceptance of the process of death and dying.
Yeah. And I would say, like, when you're talking about first responders and the trauma they're experiencing, that is very different than being a hospice nurse. I know my patients are going to die. That's the expectation. When you're a first responder, you're trying to save someone's life, probably somebody that's been in a terrible accident, and you're seeing some pretty horrific things, I would imagine. And even first responders that are responding to just a healthcare crisis, their job is to save that person's life. And if they are unable to do that, that in and of itself can be trauma inducing, because again, that's what they're trained to do, is to save them. That their good outcome is for that person to live. Our good outcome is for the person to die comfortably, peacefully, and for their family to be prepared for that and not experience suffering through watching that unfold.
Right. Yeah, totally different. For sure, as you very well articulated. Yeah, I mean, and they're coming up on people who have, in many cases have just experienced something extraordinarily tragic, and just, yeah, it's difficult to compare. But at the end of the day, death is a part of both experiences, and dealing with that is something that not a lot of people do on a daily basis. So
yeah, right.
Yeah.
Right.
Yeah. So,
and I would wonder too, and I don't know any statistics, but with first responders, how many of their patients actually die and how many of them survive? What's the ratio there? For us, we do have people that survive hospice, but it's a pretty low number, and almost all of them are still terminally ill. They're going to come back to us. Right. Like your dad.
Right.
So our ratio of death is much higher, and it is the, like I said, it's the expected outcome, and we accept that. We accept that's going to happen. And so it's easier for us to not be traumatized when that happens. And there are things that can happen with the human body where you're like, whoa, I didn't know that could happen. And you could consider that a little bit traumatizing to know that that's, possible to have tumors that are coming out of a person's body, leaking fluids everywhere, or a catastrophic bleed out can be, pretty traumatic. But they're not as common,
right,
in the whole scheme of things.
Yeah. Yeah, well, as I mentioned, I think that I think I mentioned this, that I first heard about you on the Daily Mail. I saw an article about you that came out a couple of months ago, and I was actually preparing for a near-death experience podcast that I was doing, and felt like, oh man, this would be great to get Nurse Penny in here and chat about her experiences with death and dying, because again, it is a topic that I want to explore on the podcast. I had no idea at that point in time that you had such a large social media following. So you've got, I think YouTube is maybe one of your smaller channels at 200.
It's my smallest one.
275,000 is small, right? But 900,000 on TikTok, 700 and something thousand on Facebook, 420,000 on Instagram. So what was it that really caused you to, what was the initial kind of viral moment for you?
So it happened during COVID.
Okay.
We had the shutdown, but my husband and I were still working, but everything else was shut down. The grocery stores, the restaurants, the YMCA where I was working out. He worked nights, I worked days. And so I was super bored, and I heard about TikTok. And I got on there and totally got sucked in, scrolling through, and was kind of playing around with some of the trends, trying to learn how to shuffle dance. Never did, spoiler alert. And then one day, I don't know why, but I decided to post a story. And the story that I told was about one of my earlier experiences working in hospice, when I had a patient who was an elderly woman and her daughter was a nun. And so she had a lot of nuns visiting her all the time. And one evening, the last visitor was in the room with her, and she came out to the nurse's station and she said, "She's gone." And I said, "Oh," and I stood up and I grabbed my stethoscope and she said, "No, no, no. Her body is still here doing the work of dying, but her spirit has left. You can see it in her eyes." And I was like, wow, that's really fascinating. I'm going to have to check that out. So as soon as she left, I walked into the room and I looked at this woman and I could see what she was talking about. Her neck was hyperextended, which is really common at the end of life. Mouth was open. Almost always people die with their mouth open. And her eyes were open, which people usually die with their eyes open or partially open. And they were just like, she had this fixed gaze. And the best way I can describe it is the lights are on, but nobody's there. And what she said just really resonated with me. Like, I get it. Her body is still here. It's still doing this work of dying. But her spirit, her essence, her soul, whatever you want to call it, has left. It's not in her body anymore. Is it in the room? Maybe. I don't know. Is it just gone to wherever we go after this? I don't know. But you could really sense that she was out of her body. So that video gained a lot of views. It went viral for the time. I can't remember how many views it got, but over the course of a couple of days, all of a sudden I went from having 100 followers to 10,000 followers. And I was like, oh, okay, I found my niche. I'm very, very passionate about advocating for hospice and educating on the end of life. It's my area of expertise. I'm literally a subject matter expert by virtue of being a certified hospice nurse. And people were interested in this at a time when everybody was dying because of COVID. People wanted to know more about this thing that happens to all of us. And I was like, wow, this is my thing. I'm going to do this.
That's cool. Yes, that's like divine timing then, right?
Yeah.
I mean, with COVID happening and so everybody's at home on their phones or scrolling through, and TikTok's blowing up at the same time, and death is on everybody's mind, and here you come with some original content that nobody had really dug into this prior to you, right?
No.
Yeah. Now, I mean, you see people out there now. There's other people other hospice nurses that have come out and have gained a following, but that's pretty. Well, that's weird. What did you bring with you? What did you bring with you?
Is that was your skeleton?
That was the skeleton that just fell down. Wow.
Okay, you asked me about paranormal experiences.
Yeah,
there we go,
great.
right there.
Yeah, exactly. That's funny. He's been sitting up there for a couple of hours, so that
is really strange.
That's,
it's funny because last night
they need to go home with you. Just make sure to take them back with you for sure.
You asked me last night about paranormal experiences, and I just remembered one. I've actually kind of done funny little skits about it on my social media. When I was working night, I normally work days. I don't like working nights at all, but every now and then I would pick up a night shift at the hospice care center. And we had these pagers that would notify us when a person was calling, like a room number or the front door, and the front door would be locked at 8:00. So it would say front door. So my pager would go off, front door. I go to the front door. There's nobody there. So that happened like 3 times. And I finally bumped into the other regular night shift nurse, and I said, I keep going to the front door because I'm being paged and no one's there. And she just very nonchalantly said, oh, it happens every night. It's just spirits coming to get the patients.
Wow.
And that night we had like 3 people that died.
Wow.
And I was like,
wow. That's crazy.
Yeah.
The paranormal experiences that you've had, I mean, that one, has there been much else in that you've seen?
My dad coming to me after his death.
Yeah.
But I can't really say that I've had any paranormal experiences. I haven't had dreams of my patients that I remember. I might have. When you've taken care of so many people, you forget about these things. Sometimes I'll forget about a patient and then it'll pop into my mind like, oh, that's right, I remember that one. But there is a feeling when a person dies, there's something in the room energetically. There's a shift that you can sense. I don't see it. I don't hear it. I don't feel it. Well, I do feel it. I don't see it or hear it. I just feel it. Like there's just something different in the room. But other than that, yeah, I really haven't had a lot of true paranormal experiences related to being a hospice nurse.
Do you feel like you pay attention to that, or that?
Oh, yeah.
Yeah. Okay.
Yeah.
Okay.
I mean, I believe it.
Yeah.
I didn't before I was a hospice nurse. I had no concept of afterlife, which was very anxiety producing in me. I did have death anxiety because I worried so much about there not being anything after life. I never believed in heaven or hell, have never been religious. But becoming a hospice nurse has really helped me to embrace the possibility of the probability of an afterlife. So I guess also I wonder like what qualifies as a paranormal experience, because I've seen people who were deathbed visioning, and that could be considered paranormal. So when I have somebody who's telling me my wife is in the corner, I see her, she's right there, she's coming to get me, I'm experiencing that, I guess, paranormal event through the eyes of my patient. I don't see her, but I sure as heck believe she's there. It's so convincing when you see someone deathbed visioning. You just cannot rule out the possibility that they really are seeing spirits. Right. It's very, very real to them, and it's just very convincing. So, I guess in terms of that, you could say maybe that's paranormal. I don't know, but I haven't seen any ghosts or spirits myself, other than my dad.
Yeah, that's happened in my family actually. With my mom, she had an aunt who was dying, and the aunt said that she saw my mom's mom, whose name was Betty. She said, "Oh, there's Betty," and she pointed to the corner of the room, and she was convinced that Betty was there, and everybody kind of just, deep breath in the room, like that's weird. And it was one of those powerful experiences for my mom and for their whole family who was there in the hospital with her aunt. So how common is that? Like, how often do you see that with people?
It's, again, it's really hard to put a percentage on it. I've seen it a lot. It's so common that it's in our literature. It's a sign that we consider end of life approaching. Like, we developed a tool at my agency to try to determine when people were in their last days of life, because Medicare had a quality metric around us making visits to people when they were in their last 3 days of life. So we developed a tool with evidence-based information as well as anecdotal, and mostly anecdotal because we don't do a lot of testing on people that are dying. And one of the things we put on there was that they are visioning their deceased loved ones or pets. So it's common. And people don't always express that to us. They don't always say that they're seeing those people.
Right. They don't verbalize it.
They don't verbalize it.
Right.
But I don't think that means that they don't see them. Sometimes they're reticent to talk about it because they're afraid that we're going to think they've lost their marbles, or they're dismissed by their family who says, we need medication, they're hallucinating. We don't consider deathbed visions hallucinations at all. These are not hallucinations. So they don't always talk about it. But when people get closer to the end of life, when they're going through this kind of transitioning phase where they're really more dying than they are living, they're kind of turning the corner and heading down that path to where they're going to be actively dying within the next couple weeks or so. Oftentimes they're confused and they're not coherent. They're not able to communicate, but they'll be reaching into the air. And we don't know why they do this. Sometimes we call it reaching for heaven, picking stars. There's also all different terms for it. But I've come to believe, after witnessing so many people deathbed visioning, that they are reaching for those visions that they see, because so often they are in the corner of the room, they're up in the air. And so I really think that's what's going on.
Yeah, that's fascinating. So have people ever described what it is that they're seeing?
Yes.
Okay. And
yes.
What do they say?
It's usually a person or an animal. It's a person that they know.
But in what form?
They don't really describe the form. And we don't we don't press them for answers either. It's kind of like it's their experience. And so we don't ask a whole lot of questions. I did ask one patient who told me that his wife was in the corner. Well, I was working at the nurse's station, and his room was next to the nurse's station, and he was yelling. And I knew that his wife had died a year before him. And I went into the room, and he was looking up at the corner of the room, and he was reaching out, and he was crying. He had tears just pouring down his face, and he was yelling, "Ingrid, Ingrid." And I did ask him, "Was Ingrid your wife?" And he said, "Yes, yes, she's right there. I see her." And I said, "Is she coming to get you?" And he said, "Yes, yes, but not today, tomorrow," which I thought was pretty specific. He didn't die the next day. He died a couple of days after that. And the caregiver that knew his wife said that she was always late. It was always like her to be late. So, we might ask some questions, but we don't ask them, what are they wearing? What are they, it's almost like even though you see it so many times, it's still so not unsettling, or shocking, just like profound, that you just want to experience the moment through their eyes and not really dive into what do they look like? What are they wearing? It's yeah.
Yeah, makes sense. Yeah.
I did have a lady help me looking for a cat one time, though, at the care center. And I looked for quite a while before she said, "Oh my gosh, I just realized that's a cat that I had when I was a kid, and she's dead."
Wow.
Yeah. So they do see pets too.
Yeah, I did a podcast with, I mentioned it to you, with Dr. Jeffrey Long, who's studied over 4,000 cases of near-death experiences. And one of the things that he said was that after the moment of death, people are often greeted by beings. And about 25% of the time, these beings are loved ones that they have known in their life, whether it's a parent or a spouse or a grandparent or whatever it is, that it's usually about 75% of the time, they don't know who the beings are, but 25% of the time or so, it's usually loved ones. So, that's pretty fascinating that they're actually at the end of life, they're actually able to see that prior to death. I wonder what it is. There's different stages of that people go through in hospice care. There's the transition, I guess, is the stage where people are actively seeing loved ones. Is that correct?
Yes. Yeah. Transitioning.
So where does what are the various stages?
We don't really have a name for before the transitioning period.
Okay.
Some people will say it's pre-transitioning, but we're all dying. That's what getting old is. When somebody comes on hospice, they're expected to die within 6 months or less. Sometimes they live longer than that, but and that period of time before they get into transition is kind of not eating, withdrawing socially is really common, sleeping a lot. But as they move into transition, which is in the weeks before their death, it could be weeks to days because everybody has a different kind of trajectory towards the end of their life. Sometimes they go through the stages super fast, and sometimes they linger longer, but usually transitioning is weeks, no more than 2 or 3 weeks. And that's when we start seeing the deathbed visioning, travel language where people will say, "I need to go home. I need to get out of here. I need to pack." A lot of times during transition, people are confused, and it almost seems like they're here and then they're somewhere else. Like when they're here, they aren't always aware of exactly where they are. And some people will say that's like when the veil is getting thin, which I love that because it makes sense to me. But so then they're saying, "I need to go home. I need to get out of here." So I've had many patients where I would go to see them and the spouse would say, "We argued all night because he kept saying, 'I need to go home.' And I kept telling him, 'You're in the same house we've been living in for 30 years. Home means something different to them at this point. And it can be confusing if they're in the hospital when people do this and say, "I want to go home." And people think, "Oh, they just want to get out of the hospital," and then they die. And it's like, no, they mean something different when they say, "I want to go home." They're getting ready to die. Some people will say, "I'm dying. I'm going to die soon." And of course, the family's response to that is, "No, you're not. You're going to get better." But they know that they're dying. So yeah, we see some really profound things during transition. We see the reaching into there. We see people like to do things with their hands. Smokers will be like doing this. People tying flies. I've had many fishermen who were doing this with their hands, and the family would say, "Oh, he used to tie flies. He's a fisherman." But they're not really communicating that to us. They're kind of, like I said, in and out of it. And the other thing that's really amazing that can happen during transition is that a person can have an end-of-life rally, where all of a sudden they just wake up with a burst of energy. They're very lucid. They want to eat a meal when they haven't been eating for, days or even weeks. They want you to call all their friends. Somebody told me once that they had their person on hospice had a rally where they wanted to play bridge. She woke up all of a sudden and said, "Can you just call my friends? I want to play some bridge." And it doesn't usually last very long. It usually lasts about a day or less. And then they go back into this either transition or actively dying phase where they are close to the end of their lives. So people think when their person goes through a rally, they think they're getting better. But in reality, we have to manage their expectations because they're close to death when this happens.
So when they're talking about going home, do you feel like they're talking about going to heaven or some other place that's not physically their home, but wherever they came from?
Well, I think that they're talking about death, whatever that means to that person. If they believe that it's heaven, then that's what they're probably referring to. But I think just generally speaking, they're talking about leaving Earth. They're talking about dying.
Okay. Yeah. Okay. And then, so you've got the end of life rally. What do people, so can that, you mentioned to me last night, my dad has Alzheimer's and he's very much end of life. And you mentioned to me that oftentimes even Alzheimer's patients can get to the point where they are all of a sudden talking again.
They're lucid.
Lucid. And so what does that look like with Alzheimer's patients specifically? What have you seen people
recognizing their loved ones?
Okay.
Recognizing people.
Okay.
I was telling you about a patient that I had who grew up in Germany but did not speak German for the whole rest of her life. And then at the end, she had some lucidity where she was able to speak German again. So yeah, it's usually recognizing people. And I hear this all the time from people who follow me too, who will say, that's a beauty of social media is that whenever I do a video talking about this, people get in my comment section and they validate each other with their experiences. And many, many people will say, yes, my grandmother who had Alzheimer's recognized me and told stories about when I was a kid. And, it's amazing that this happens. And we don't know why. And it's fairly common. There are statistics on that. It's about 4 out of 10 dying people will have an end-of-life rally.
Okay.
And there's theories as to why it happens, but we don't test. We don't do tests on people who are dying. We're not going to draw blood on somebody who's on hospice. So we don't have tests, but some doctors have surmised that it might be that as their organs are shutting down, they're releasing hormones, which makes sense because steroids are hormones and steroids can give people a burst of energy. So it makes sense that could be what it is. But I also like the idea of not really knowing because I just think there's something magical about the dying process that makes it more tolerable for us to be able to believe that there's something after we die, makes it more acceptable and tolerable. And so these things that are just unable to be explained, I think are best left that way.
Right. What is it? What have been the most convincing things for you that have been convinced you that there is something next after this life?
Deathbed visions.
Yeah.
Okay. Absolutely. Yeah. When I went through nursing school, I learned in chemistry that nothing ever really goes away. It just changes its form, and a lot of times that's into the form of energy. And I believe that our spirits live on in the form of energy. So I was a hospice nurse for 5 years before my dad died. But already by the time he died, I had formed this belief that there's life after death because of seeing people deathbed visioning. And then when my dad came to me in the form of energy, that was just like, yep. It just, firmly convinced me 100%. That's my belief,
Yeah. It's a belief, but it's based on experience.
It's based on experience. Yeah.
Yeah. A lot of beliefs are not based on experience. They're just
beliefs.
They're just beliefs.
Right.
Yeah.
Exactly.
Yeah.
But, and I always say I'm not trying to convert anybody to believe what I believe or to convince them that there's life after death. You can believe what you want. It either is or it isn't. If it isn't, then we won't know because we'll be dead, which my ex-husband used to say to me all the time. It did not help my death anxiety, by the way, when he said that. But, I just feel like I do believe that there's something after this. If I'm wrong, it won't matter.
Yeah, right. Exactly. Yeah. How I know it can range, but how close to the actual point of death do you usually have these, or do you usually see these rallies, these end of life rallies? They
usually die within about a week.
Okay.
And people can go longer than that. Again, death is really unique to the person who's dying. So sometimes something can be different, but on the average, it's usually they're going to die within about a week. And it almost always lasts less than a day. It's really like a very short window of time.
And why do you think that is?
I don't know. I mean, because I don't know what causes it, so I don't know. If it is like a flood of hormones, maybe it excretes out of the body and then it's done. I really don't know.
Yeah, we kind of skipped over your background, where you're from, kind of your childhood and sort of, talking about you a little bit. So why don't we do that real quick? I know it's all in your book, which Influencing Death, which you wrote and just came out a couple of months ago, right?
Yeah. January.
Yeah. But if you could maybe just talk to me a little bit about where did you grow up? What was childhood like?
I grew up all over the place. So I was born on Guam. My dad was in the Navy. My mom was Canadian. They met in Washington and Whidbey Island and got married 3 months after they met. And so I was born on Guam. And I always say I'm an island girl. I was born on Guam, raised on Whidbey Island, but also lived in California because of the military. I lived in Oregon. I lived in Florida, Connecticut, Okinawa, Japan, but mostly Washington, Western Washington, and most recently have been living in Eastern Washington. So did not really embrace college after high school. I thought I was going to be a rock and roll singer, so I didn't need to go to college. Got pregnant when I was 20. Got married to a sailor, so traveled some more, and kind of was a hot mess for a long time. Didn't really get my life together until I was 40. 30, I would say. 27, went through treatment, but prior to that had been a drug addict, gave my son to his dad to raise so I could party. I was a bartender. I lived in the bars, really aimless and kind of useless and worthless, but did finally go through treatment when I was 27, turned my life around, remarried, a military man again, had a couple daughters, got my son back, and then 10 years into that marriage, started realizing that we just weren't right for each other and decided to get divorced. And because I had been a stay-at-home mom with the kids, homeschooling, I needed a career. We knew that, this day and age, you can't really survive on alimony and child support. And so I decided to go to nursing school. And I really was at a time in my life where I just wanted to make up for all the things that I had done when I was younger and kind of be more productive in society and give back to the universe. And so when trying to decide what kind of a nurse I wanted to be, I thought about my former stepmother-in-law who had died a year before I went to nursing school. She was on hospice. I felt like the nurses were just very gifted in what they did. The work was sacred. It felt like really special work to me. So I knew that's what I was going to want to do. I also had severe death anxiety.
Interesting.
Yeah, like I said, my husband would say, well, if there's nothing after we die, then you don't have to worry because you'll be dead. And so I always say jokingly that's what led to our divorce. But so I kind of had a morbid curiosity, a fascination with death. And then I thought maybe this will be like, was it immersion therapy when you expose yourself to something? Maybe that'll help. I was right, by the way. So I became a licensed practical nurse first, and I did not think I could work as a hospice nurse, being a licensed practical nurse. So I went to work in a clinic, and then I was there for a year, then went to work in a hospital for a couple months, got laid off. They lay off LPNs frequently. And during that time had met somebody new, and there was a hospice care center in his neighborhood. And I thought, well, you know what? I should just go see if they're hiring LPNs. And they were. And so I was hired, and then I loved it so much. I stayed with it. And through the years, I got my RN, my BSN, and my certification in hospice and palliative care nursing. And I've pretty much been in it ever since. So that's like my whole life story condensed down for you.
That was a quick version. Thank you. Appreciate it.
Still, it's probably too long, but
no, it's perfect. And you've quit drinking. You're sober for 4 years. You said
almost 5. It'll be 5 years in October.
Congrats. That's cool. I'll be 3 years in October.
That's awesome. Yeah. Congratulations to you.
Thank you.
Yeah, I had like a 30-year relapse.
Okay.
They say alcoholism is progressive. And it is, and definitely I managed it for a long time, and then came to a point where it was no longer manageable. And I tried everything. There's lots of things that you can try to do to quit drinking, but in the end, the only thing that works is to stop picking it up and putting it in your mouth.
Right. Yeah, exactly. You got to break that pattern. Well, good, interesting, fascinating. You got a great story. I guess one thing for me about the way that we talk about who we are and spirituality in this life with this English language that we use I feel like can be kind of confusing and maybe lead to a lot of the just the misconceptions that we have about death and the fear that we have about death and just kind of the I guess part of just kind of how we deal with death as a society. Like, we talk about dying as if we are going away or, it's the end of something. But in reality, it's not really the end of us. I think in your mind, in my mind, it's not the end of us. We continue spirit. We're not a human being having a spiritual experience. We're a spirit having a human experience.
My favorite saying.
It's great.
It's my signature line in my email.
It's so true.
Yeah. It's Jean-Pierre Tillard, I think, that said that. Yeah.
Yeah.
I love it. I mean, that resonates with me so much.
Right.
I really believe that.
Right.
Yeah.
So when we talk about we're dying, it's really the body that's dying. It's not the spirit that's dying. And the body is something, I feel like we all kind of confuse who we are. We confuse who we are for our physical body, and we kind of don't realize that we are the spiritual body and that we're not really dying. We're just transitioning to something else.
Right.
So is that, I guess, thinking of that and thinking about just the whole process of death and dying and kind of communicating to not only the individual that's dying, but the family members that are also a part of this experience that you have to communicate with, I'm sure, right, on a daily basis. Like, how do you talk to people about the process to make them, feel comfortable and feel okay and just, not have all of that resistance to the whole process?
Well, normalizing. And it's not my job to tell people what I think happens, but I do validate their experiences. If they see that their person is talking about seeing their deceased loved ones, then I validate that. Yeah, we see that all the time. It's really normal. It brings comfort to them, and we don't want to medicate that away. So it's really more explaining things that are normal and validating what they're seeing. I would never say, yeah, he's seeing spirits of his deceased loved one, because I don't know if that's what they believe. And that would be kind of the same as proselytizing, which we also don't do. We don't try to convert people at the end of their life. If they want to go into, well, what do you think is happening? Do you believe there's spirits? I would say, it sounds like spirituality is really important to you. I would love to have the spiritual care counselor come and see you and talk with you more about this. Because we do have their spiritual care counselors, also known as chaplains, who are trained in that. They have a master's degree in divinity. That's what they know. That's their knowledge base. And they're coming at it from a learned experience through education, not just their own belief, right? They like understand all the different beliefs that are out there. So it's not for me to try to dive into those conversations with people as much.
What if you do have like a family that comes in, say you've got an atheist who's dying, or somebody, just a spiritual person potentially that's dying, and their family is very highly religious and wants to kind of, convert them at end of life. Is that, you see that?
Been there, done that.
Yeah, okay.
Yeah. Again, it's my job to be protective of the patient and to advocate for them, and would ask that they have the chaplain come and talk with them. It sounds like religion is really important to you. He's expressed that it's not as important to him. I think it would be great if we could get the chaplain out here to have a conversation.
And so what are those, has there been conflict between you and family members at times, or?
Not so much over that. I mean, there's been conflict. I've been fired. If you're a hospice nurse for any length of time, you will have been fired by at least one family who just doesn't get along with you.
Yeah.
I'm very straightforward, and most people really appreciate that, but there's some that don't want it. They don't want to hear it. They don't want to talk about it. So yeah, no, I really haven't had, I think I'm offering them an alternative suggestion, like, how about instead of this, we get somebody in here that can talk with you more about this? And that's what my role is as the nurse, is to make sure that I'm the case manager. I'm the one who's managing the care of that person. So I need to identify who on the team, because hospice care is a team. It's not just the nurse. We get all the credit, but it's an interdisciplinary team. It's really one of the few areas of healthcare where there is an interdisciplinary team. There's an aide, there's a chaplain, there's a social worker, there's a doctor, a nurse practitioner, volunteers. The family is part of the team. The patient is part of the team. So I am to manage the care of the patient by bringing in the appropriate team members.
Okay. So what does the chaplain have direct responsibility for then?
For addressing the person's spiritual needs.
Okay.
And a lot of times people will just out of hand refuse the chaplain, and I really try to get them to not do that. And I can come from a place of experience with that, because having not been religious, before I became a hospice nurse, I was going in for major surgery, and the chaplain came to speak with me. It was a military hospital. He was a priest, so he had a military outfit on with a priest collar, and I thought he was coming to minister to me because he thought I was going to die, and it freaked me out. I was like, I don't want somebody like trying to convert me, and that's not what they do. And so that's what's really important to me when I'm talking with families, is to educate them that the chaplain is not going to try to convert you. We have atheist chaplains in hospice. We have Jewish chaplains. We have Catholic chaplains. We have, every denomination that there is, Buddhist, Muslim, but they're experts in not only their area of religion that they practice, but all areas of religion and spirituality. So they will help the patient with whatever their self-identified, not what the family identifies, but their self-identified religious or spiritual needs are.
Okay. Yeah, it's interesting that religious people are chosen to be the spiritual guides for people. They are two completely different things, religion and spirituality. Religion is much more of an outward look and attempting to find God outside of you, and spirituality is more about the recognition of God is within you, and so it's.
But religion is rooted in spirituality.
It is 100%.
Yeah, and like I said, there are atheist chaplains, so it's not just because some of them are religious. But religion and spirituality are connected to each other.
Do you find that the religious people I guess they have to be consummate professionals to be able to do what they do and to not push their beliefs on other people and to truly focus on an inward spiritual look with the
Yeah,
patients.
absolutely. Yeah. Any chaplain who is proselytizing shouldn't be a chaplain, because that's not their job to do that.
Right.
They're knowledgeable in all religion. They have, like I said, they have a master's degree in divinity. They are knowledgeable in religion. But also, as a part of their training, they should know that it's not their job to be pushing their belief onto their patient. If they are, they're unethical, and they shouldn't be a chaplain.
Right. That makes sense. And so so when you're talking to people, so let's talk about the patients first, and then maybe go on to the family. I'd like to just understand how you communicate with family and whatnot as well. But for patients, like what are the do's and don'ts in terms of what do you say to them, what don't you say to them, and what's your goal? I mean, your goal, I guess, is obviously to establish peace and calm and comfort. But in what ways do you, and what else is there beyond that? And in what ways do you attempt to do that with the patient?
I always start from a place of wanting to find out where they're at with understanding what's going on. And from there, going to what do you want to know? And then meeting them where they're at. And sometimes they don't want to know. They don't want to talk about it. So the don'ts are don't go places with them if they're not ready for that. You have to allow them, to determine what they're comfortable with talking about. But definitely, what do you understand about this? Because I've had patients who came onto hospice who didn't know that they were dying. I had a patient in the care center who was 28 years old with colon cancer. And she came in because she had severe constipation. And so she came in and we got her constipation taken care of. And I was packaging all her medications up for her to go home. And she came out to the nurse's station and I said, "Oh, I'm just getting your meds ready for you to go home today." And I thought she'd be like thrilled. She's going home. And she looked at the medications and she said, "Those are all for me?" And I said, "Yeah." And she said, "I wasn't on anything before I came here. Why do I have to be on all these meds?" And I said, "Well, the doctor thinks that you have weeks to months left, and we want to make sure that your bowels are managed and you don't end up back here again." And she freaked out. Weeks to months? The doctor said I had a year. So her oncologist told her that she had a year left, and then referred her to hospice, knowing that the qualification is a life expectancy of 6 months or less. So that was a lesson for me, is know what your patient knows before you go in there with a prognosis. So really finding out, what do you understand? I've had lots of patients that came to hospice and their doctor told them that hospice could give them more help. They don't understand that this is end-of-life care, and I explain that to them.
And is it usually young people that are confused about the...
No, old people too.
Okay.
Oh, yeah. I had one patient, a very old. He was in his 90s. I think he was like 92. And he had a heart condition, fell and broke his hip, and was not a surgical candidate. So they put him on hospice and sent him to us at the care center. And he was furious. He was livid, and his wife was too. I remember taking her into another room to talk. She didn't want to talk about it in front of him. I respect that. Took her into another room, and she was so angry that the doctors wouldn't do surgery because he was too high risk. And I said, surgeons, it's their job to do surgery. So if they're saying they don't want to do it, there really is a risk to it. And they really feel like, he's end of life. And she signed him out and took him home.
So how do you tell somebody then, if somebody doesn't even know that they're end of life, like what are you just very matter of fact about it, or what's the approach?
I am compassionately, I will say, well, hospice means that, he has, or you have, whoever I'm speaking to, the family or the patient, a life expectancy of 6 months or less. And of course, we don't know for sure. But that is what
could be longer.
It could be longer, could be shorter, but that is what the doctor is estimating as far as how much time you have left. And we focus on you living your best life for as long as you have your life. So we're not going to do anything to try to cure your condition, but we are going to make sure that you are as comfortable as you can be while you're still here. I love the saying that hospice doesn't add more days to your life, it adds more life to your days.
Nice. Yeah. And you find yourself forming, obviously, strong bonds with the people that you're working with?
The families more usually than the patients,
Okay.
because, well, for one thing, patients always come onto hospice way too late. The length of stay is much shorter than we would like for it to be. Most people die in less than 6 months. And we do have those that stay longer on hospice, usually dementia patients who we don't get to know as well because they are profoundly demented by the time they qualify for hospice. So
Sure.
we interact with the families a lot, especially when the patient becomes unresponsive or they're in that transitioning period where we're not able to communicate with them as much. And so we're really spending more time with the families. So it's easier to form a stronger bond with the family than with the patient. But again, it's at the end of the day, we're there to do a job. So once the job is over and the person dies, then we are no longer seeing the family. That's just how it works in all areas of healthcare. Once your disease is treated, you don't go out and have drinks with your oncology nurse, because it's my job. It's what I do. That isn't to say that I didn't care about them, that I don't still think about lots of them. I still do. There are still a lot of family members that I think about and wonder about. But my agency and most agencies will not let you maintain a relationship with the family once the patient dies. It's not ethical to do that.
Okay. Gotcha. What are the most common reasons why people come to hospice? I mean, like from cancers, obviously.
I think cancer is probably one of the top.
Okay.
Medicare will publish the list of the top diagnoses, and I believe cancer is probably the top diagnosis for.
Okay. And what else after that?
Heart disease, dementia.
Okay.
ALS, down the line.
Sure.
ALS, Huntington's. We see Huntington's chorea. That's pretty awful. We used to have failure to thrive, which is just old people with a whole bunch of conditions that are all coming together. And then Medicare said we can't use that anymore. And so then we had debility, not otherwise specified. And they said you can't use that anymore. So the doctors are always trying to figure out, like, what is the terminal diagnosis for this person? Because you have to have one for them to qualify for hospice. So if it might be renal failure, if they're diabetic and their kidneys fail.
Okay.
Yeah, there you go. Cancer, dementia. I don't have my glasses on, so I can't read the heart disease. Yeah.
Heart disease, lung disease.
Lung disease. Yeah, lung disease. Liver disease is probably on there somewhere too. Yeah, but cancer, number one.
So, I mean, smoking a lot, drinking.
Smoking, drinking, that's another thing that'll make you quit. Although, ironically, I was a hospice nurse for 16 years before I quit drinking. But yeah, for sure. I've had a lot of, and that's, I talk about that in my book too. That really made me reflect a lot when I was taking care of patients who were dying from smoking or drinking. I was a 3-pack a day smoker. I've quit now for, I think, 32 years it's been since I quit, but I worked in bars for 8 years. I was a bartender and I smoked like a chimney. And so whoa, I'm very, very lucky that I didn't end up with a smoking related disease. But yeah, smoking is bad. And those types of diseases are hard to watch people die from. It's really hard to watch your person die from liver disease when they have just extreme agitation and confusion, combativeness. It's really, really hard for families to see their person devolve into that condition. For patients dying from smoking-related diseases to feel air hunger, suffocation, they can't breathe, they can't get their breath is very, very, hard to watch and hard for them to experience suffering.
Yeah, my grandmother had a stroke, and I actually was the one who found her. My parents were out of town. She was at my parents' house, and my parents hadn't heard from her in 2 days, and so they said, "Matt, can you go over and check and see if you can find Grandma?" And so I went over there, and the car was parked right in front of the house. The door to her car was open, and she was laying like she had fallen out of the car and was kind of halfway out of the car, halfway in the car, and still alive. But
wow.
yeah.
How long had she been like that?
She'd been for 2 days.
And nobody called EMS or anything?
Nobody had. No.
Wow.
Yeah. I guess it wasn't abnormal to just, it's been a couple of days. We hadn't talked to her.
She must have lived in an isolated place and didn't have neighbors that cared.
For sure. Yeah.
Wow.
Yeah. They had a big, it
2 days.
was isolated.
Oh my gosh. That's a long time.
It might have been 36 hours, but it was more than a day.
3 hours is a lot for someone to be on the ground.
I know. And so I ran up to her, and grabbed her hand and said, squeeze my hand if you know that I'm here. And she squeezed my hand. And that was, after that, she was completely irresponsive. She never, did anything. So we called the ambulance and brought her to the hospital, and they put her on the air, I guess, oxygen to breathe, and put the tube down her throat so that she could breathe. And so she was in the hospital, and just, very traumatic for a 22-year-old kid to see and do all that stuff. And then, I just remember being at the hospital, and they made the decision, we're going to take the air tube out because she's, not responsive. And just remember the air tube coming out, and just the gasping for air is just awful. It's just for.
And that was probably normal end of life. I imagine they medicated her. Like, we don't extubate people before medicating them. And hospice does compassionate extubation.
Yeah.
We medicate people before we would pull that tube out.
Yeah.
I say the doctor pulls it out. And I've never seen it done. I know that we do it, but I've never seen it done. They usually extubate them before they send them to the care center. But people gasp at the end of life. That's very, very normal breathing pattern. We call it agonal breathing, fish out of water breathing, where they look like, and people, this is one of the things I educate about, because people are thinking, oh my God, they can't breathe. They're suffocating. It's awful. But really, they're not experiencing that anymore. It's an autonomic breathing pattern that they're doing. Almost everybody does that at the end of life when they die a natural death. And
but this wasn't natural. I mean, she was able to breathe until the moment when the tube came out, and then she had to gasp to get air. I remember the look on her face was like pure.
So she was alert when this was happening?
Her eyes were open. The
Wow.
look on her face was of total surprise when the thing was pulled out, and she was like, it was basically like, what the hell? Why did you take that away from me? Like, why did you take
that's not normal.
Yeah.
Normally they get morphine is the gold standard for that, and Versed would sedate somebody. How long ago was that? A long time ago?
This was, I was 22, so this was 24 years ago. It was right around the year 2000, I guess.
I guess hopefully they're better at it now, but compassionate extubation, they medicate them first. They don't just pull out the...
Right.
Yeah, they don't do that.
I think they thought that she was, just totally gone.
Yeah.
So she, but as it turned out, she was, I guess, not quite there.
Yeah, and even if they thought she was gone, they should still be medicating.
Yeah, right.
Yeah, we still medicate people who are actively dying. We assess for discomfort and we can tell when people are uncomfortable. We look at their face. They get furrowed forehead, and you can tell when they're uncomfortable. So even when someone's actively dying, we will medicate them just to make sure.
Morphine
morphine is the gold standard. So it's what we've used for decades successfully, and it's cheap. And hospice doesn't really get paid a lot of money. Hospice is paid a daily flat rate for every patient, no matter what we're doing for that person. It's not like if you go to the ER and they give you a little basin to puke in, there's a yellow ticket on there, they stick it on your chart, and everything that you get in the ER, there's a yellow label on it, and they put it on your chart, and they bill you for each thing that they give you. Hospice is a flat rate. So whatever we do for our patients, we get paid the same no matter what it is. So we are always looking for the least expensive way to do things, and morphine is cheap, and it's tried and true, and it really is the gold standard for treating shortness of breath or air hunger where they can't catch their breath. It works so well. So that is typically what we use. But we use other opioids as well if we need to. Oxycodone, Dilaudid, fentanyl, methadone. There are lots of other medications that we use. Fentanyl patches. Yep. Fentanyl lollipops. Yep. Fentanyl infusions. We don't use fentanyl infusions in home hospice as much just because of the way we deliver infusions at home is usually through a subcutaneous route, which is just a little tiny catheter under the skin. And fentanyl concentration is too high or too low, and it requires more volume than a person's body can absorb with that method. So it's better for somebody that has a port, like intravenous access.
Mm-hmm. And it's ultimately up to the patient, I guess, if they have the wherewithal to make the decision.
If they have the ability to make the decision, then yes, it's always up to the patient. The family does not have that decision-making capability until the patient can no longer decide for themselves, and then it's whoever their legal healthcare representative is. And it's important to make sure that you have a legal healthcare representative that will speak on your behalf for what you want, and that you tell them what you want. Because a lot of people, if they don't know, are going to err on the side of what would they want for themselves or what do they feel is best. And if they're afraid of a drug, morphine, fentanyl, whatever, then they're more likely to say, no, I don't want them to have that. So, you really have to have conversations with your decision maker.
And do you often see that it's a complete change of direction after the person is unable to make their decision?
Not often.
Okay.
But sometimes, and usually when that happens, they haven't designated a healthcare representative. And so you've got family members now. There's a hierarchy in my state. I don't know how all states work, but in my state, like it's the spouse first if you're married. If you're not married and you have adult children, it's your adult children. If you don't have adult children, it's your parents if they're living. If they're not living, it's your siblings. So, for example, I have a patient with 5 siblings. They all have to agree on whatever it is that we're going to be doing. And they may not be on the same page with each other. And that can delay care to a person because they're trying to decide, like, what are we going to do? We're all wanting this, but Mary is wanting that. And they all have to be in agreement.
Yeah. What are some of the more maybe volatile or more interesting kind of interactions that you've had with a patient's family?
Well, I have a great story about this in my book. I had a patient whose son was living with her adult son, and he was not accepting that she was dying. And he was not providing very good care to her. She was getting wounds, and we see wounds on patients' bed sores, is what they used to be called, pressure ulcers. And he wasn't medicating her appropriately. She had broken hip, and every time I went to see her, she was in excruciating pain, and I would have to give me the medication. And he was not the legal decision maker. His sister was. But she worked in a bank. She had a high-paying position, important position, and was not always there. And so the son was taking care of the mom, and he wasn't medicating her. And so I finally my social worker and I had to call his sister and get her involved, and she ended up getting custody of her, taking custody of her and putting her into a nursing home. And he was going to the nursing home and badgering the nurses and getting in the way of her getting care and telling them, you can't medicate her, you can't give her morphine, I don't want her to have morphine. And they finally kicked him out and said, you can't come back. And I was there visiting her, and he showed up with a friend and was going to try to bully his way in there. And I said, you can't come in here. And they were going to call security, and his friend was like, man, let's just get out of here. We don't want to cause any trouble, And he went outside, and I went out. This guy was tall, and I was just like right here, looking up at this big guy. And I said, you cannot keep bullying the staff. Your mom is dying. And if you want to be with her, you have to let them take care of her. And I saw this guy just break down in tears. And it was heartbreaking, really, because he just wanted to do what he thought was right for his mom. But he wasn't acting on her behalf. He was acting on his own. I hate to use the word selfishness, but it is what it is. He didn't want to lose his mom. And so I was able to get him to agree that he wouldn't interfere anymore. And she was really lingering too. She had been lingering in the nursing home for a while, past where we thought she should have died. But I went back in and I spoke with his staff and I said, he will behave himself. He'll let you do care with her. And he went back in and he sat with her and he held her hand, and she died that day with him there. So she needed for him to be there, but he wasn't able to be there as long as he was interfering with her care. So that's one that really, really sticks out in my mind.
She died that day.
Mm-hmm.
Wow.
Yeah.
Do you ever get the sense that that people can kind of choose?
Yes.
Yeah.
Yes.
Okay.
I knew you were going to go there.
Yeah.
That's another favorite topic of mine.
Yeah.
Because many people do seem to have control over when they die, whether it's they're waiting for something or someone, or they're waiting for someone to leave. And more commonly, I've seen them waiting for someone to leave. And that makes the family feel so bad. They feel so guilty. I was with him. I sat there by the bedside for the whole day. I stepped out to go pee. I came back, he was dead. And it happens so often that we do believe that people have the ability to control when they want to die.
Do you think that it's more that people are really choosing the exact moment, or do you think that people are intentionally holding on for a longer period of time?
I think they're holding on and waiting for that time.
Yeah.
And then when they finally leave, they're able to do it.
Right.
It's amazing to see that. I have vivid memories of being at the care center. I can picture it in my mind right now, this room full of people and the lady in there dying. And one of them, the adult son, came out and said, we're going to go get breakfast. We think we need to leave for a few minutes. And the door had just shut after the last one of them left and gone just like that.
Wow.
Yeah. We had another guy. I didn't tell this story in my book, and it's one of my favorite stories. But we had this guy who was there with his uncle, and his uncle raised him. He was very, very close to him. And he was like, I am not leaving. I want to be with him. He raised me, and I want to be with him when he takes his last breath. And he was there day after day after day for like a week. And finally we said, you're probably okay to go get something to eat, because he was living on the soup and cookies at the Hospice Care Center. We're just right up the road. There's a restaurant, Go up there. You'll probably be fine. He's been lingering all this time. Sure enough, he died while his nephew was out of the building. So when he came through the door, we were watching for him, and the other nurse I was working with ran into the room and grabbed her stethoscope, and I walked him down and I said, "Come, you got to come on right now. He's taking his last breaths right now." And I walked him down to the room, and she had her stethoscope on her chest, and we grabbed his hand and put his hand in his uncle's hand, and she said, "He just died." And so we let him think that he was with them when he took his last breath, but his uncle needed for him to not be there.
And why do you think that is? I mean, it's such a personal. Is it just because it's that the act of dying is something that people don't want others to observe happening?
It could be that. It could be that. They're private people. A lot of times, people who are very private want to be alone when they die. But also, I think it's protective, because I've seen moms do that with their kids. They don't want their kids to be present when they die. So I think it's protective.
Okay. They don't want their kids to.
They don't want their kids to experience
memory
that.
Or experience. Yeah.
I mean, we don't really know, but that's just based on what I've seen, is that there are people who were very private. I had another patient who's he was a man with 2 adult daughters and a second marriage wife that were there, and a dog under the bed. And when I got there, he transitioned like right in front of me. I was just, oh, wow. Like, I think he's going to die in any minute. Like, I really see these very, very end of life signs, and I think he's going to die really soon. And so each one of the women grabbed a body part, one at each hand and one at the foot, and they started stroking his hand. It's okay. It's okay. We're here. It's okay. We're here. And I said, I'm just going to go step out of the room and go do some charting. Come and get me when you're ready. So I was in the kitchen. I'm like there for 20 or 30 minutes, and I'm thinking, dang, he should be gone by now, you know? So I went back in there. They're still, it's okay, Dad, we're here. And I said, is he the kind of guy that would want you doting on him while he was alive? And one of the daughters just looked at me, her eyes got wide, and she just dropped his hand and she goes, I got to go to the bathroom. And then the other two women, same thing. They just all just made a beeline for the door. And so then it was just me and the dog was under the bed. So I walked out into the kitchen and I said, sometimes we keep people here. We don't mean to, but we keep people here. And for as long as that conversation took, 1 minute, 2 minutes, I turned around and walked back in and he was dead when I went back in the room.
Wow. Yeah. So, yeah, that's pretty incredible. I mean, it makes total sense that people would want to, do that on their own without people around them. I mean, and then just and then not have the other loved ones experience that moment.
Yeah.
As well, for sure. So that's fascinating that you can hold on for extended periods of time.
Yeah, or holding on for an event sometimes too. Or holding on, and that seems more deliberate. They're more awake when that's happening. I think when it's more profound is when the person is dying and you're like, what is going on? And I always say, because families will think their person who's dying is suffering if they're lingering. So my catchphrase is lingering does not equal suffering if that person who's dying is comfortable, but it is hard on the family. The family is suffering. And death takes as long as it takes, and sometimes it takes a while. And we don't know what's going on in here when a person's dying. We don't know if they're going through life review. We just don't know. But there comes a point when sometimes even us, the hospice professionals, are like, what is keeping them here? And we start to say, is there somebody they haven't talked to? Is there something they were waiting for? And oftentimes it's somebody that they haven't said goodbye to. A sister that lives on the East Coast. And I would get the phone and hold the phone up for the patient so that they could hear her voice. And then they would die shortly after that.
And is the moment of death typically peaceful?
Yes.
Yeah.
Yeah. The moment of death is, and even leading up to it, most people are peaceful. When people come onto hospice, usually their initial reaction is fear. Like, oh my gosh, I'm for real dying right now. And you just proved it by putting me on hospice. But they will almost always work through that and get to a place of acceptance. And then if they're scared of anything, it's not of death or what happens after death. It's either what is dying going to be like for me? Will I suffer? Will I be in pain? How is my family going to be? Those are the things that people worry about when they're dying. And so by the time they're dying, they're usually just they're okay with the fact that they're dying. I had one patient in the hospice care center who was very, very fearful until the end. And he had a lung disease. He was young. He was in his 40s. He was alone. His family wasn't present. And I went in there with the hospice aide, and I was standing on one side of the bed, and I took his hand, and I gave him all the medication we could possibly throw at him. So I'm standing at one side holding his hand. She's at the other side holding his hand. And I could just see the fear on his face. And he was just struggling and struggling. And all of a sudden, he looks up and peace just washed over his face. And then he died. It was unbelievable. And I looked at the aide and I said, have you ever seen anything like that? And she said, never. Have you? And I was like, never. I mean, it was an experience that words can't do justice. I can't even describe it adequately. To see this, it was just like peace. It just, yeah. And that's the only time I've ever really seen somebody be fearful right up until their death.
And so between the very final moment of fear and then that face of peace and then the death, how many seconds?
Seconds. I mean, I couldn't tell, just a few seconds, just like long enough for us to observe this, and then death.
So we talked about the transition. We talked about end of life comebacks and rallies,
terminal
right?
lucidity.
Exactly.
Yeah.
Yep. But what about the actively dying phase?
Actively dying is really when a person is, usually hours to days away from death. Sometimes they can go for a week. I did have one patient that went for about 3 weeks. They are completely unresponsive during this time. They're not eating, they're not drinking, they are not putting out a lot in the way of excretion, urinary or fecal output. And we can't get any kind of response out of them. There's no meaning or purpose in any response that they have. Eyes are almost always open or partially open, although some people will have their eyes closed during this time. And if they are open or partially open, they're going to have that fixed stare I was talking about with the lady that had the nun visitors, like looking at heaven or whatever you want to call it, like nobody's there, neck hyperextended often, mouth hanging open. This is all because of a lack of muscle control in the face as they're dying, and breathing patterns changing all over the place. So they could have deep breathing, shallow, labored, like just changing from 1 minute to the next, long periods of no breath at all. We often will see people have a death rattle, which is also known as terminal secretions. So this is because as people get close to the end of life, they're not swallowing anymore. So we're swallowing our spit down all day long and we don't even realize it. But when a person's dying and they're not swallowing, that spit builds up in the airway. So when they're breathing, it makes a gurgling or a rattling noise, which is very disturbing to the family, but the patient is unresponsive and unaware that it's happening. And the death rattle is highly predictive. About 77% of people that have a death rattle will die within 48 hours.
Wow.
Also, an end-of-life fever is really common.
It doesn't cause the death. It's just
it's just a byproduct of the dying process.
Right.
The fever can develop in like the last 72 hours.
Okay.
That's really common at the end of life too. But this is just kind of like they're in the holding pattern for however long it takes until they breathe their last breath.
And do you ever feel as if their actual spirit energy has left their body during this stage?
Yeah, that's during the time when we really see that glazed over look in their eyes, and it just doesn't appear that they're there anymore.
Yeah, and what is that? I mean, how do you communicate to the family what's going on, and that this is really they're near the end?
They can see it happening, so they know, and we've been guiding them along the way, hopefully, if we've had enough time while they've been on hospice. But I would say we're looking at a very short period of time. So when we give time frame estimates to our family members, we give it in a time frame. We say weeks to months, days to weeks, hours to days, minutes to hours. And so I would say, it looks like we're probably on our last minutes to hours. And I would also tell people, I'm going to give you the worst case scenario. That way, if I'm right, you're prepared. And if I'm wrong, it's a gift, and would give them the estimate. Although when they're in the actively dying phase, this is the time when the family's kind of ready for it to be over, wanting for it to be over. And that's when it becomes more about they're stressed because they're waiting for the person to die, which is anticipatory grief. Earlier on, they like to have the bigger numbers. They want to know there's more time left because they're still appreciating that person being in their life. But once they get into that actively dying phase and they know what's going to happen, that's when it's a little more difficult, when they're kind of, I don't want to say wishing that their person would die, but waiting for that to happen. And that feels so wrong to people, to be waiting for their person to die.
I guess once they're checked out, there's not much else you can do except to wait.
There's
right?
nothing you can really do. Yeah. You're not communicating with them. They're not communicating with you. You can still talk to them. There's been studies that have shown that people who are dying can still hear up until the last moment of death. So we encourage families to talk with them, lie with them, be with them. One of the most compassionate things I ever witnessed was when, first of all, let me preface this by saying, I don't like euphemisms. I don't like to say passed away, gone to heaven. I've seen how confusing that can be for people when they're stressed out and emotional about what's going on with their person. We use the words death, dying, died. It's important to use those words. And people will say to me, well, it's just a lot nicer to say passed away. It's just more compassionate to say passed away. And I always say, you can say that somebody died or somebody is dying really compassionately. Like, I don't walk in and say, oh, he's about to kick the bucket. There's a way to be really compassionate. And I was working with a nurse at the hospice care center. I was a fairly new nurse. She was really experienced. And our patient was transitioned and was now actively dying. And so we could see he's probably not going to live very long. People, they maintain kind of the same trajectory on this pathway. So if they transition really quickly, they usually move towards death really quickly. If it takes longer, it's kind of a slower decline. So we saw that he was transitioning really fast and that he was going to be dying soon. And his daughter was freaking out. What's happening? What's happening? And this nurse went over to her, and she was 6 feet tall, and she looked down at this lady and took her hands in her hands, and she looked into her eyes and she said, he's dying. Be with him. And she walked her over and she sat her next to him, and she put her hand in her dad's hand, and she just was able to relax. And then she was able to sit with him until he died. And it was just the most compassionate thing I've ever seen. And she used the word, I just took you all over the place with that.
Mm-hmm. No, that's okay.
We went from actively dying to anticipatory grief to euphemisms.
Yeah, and I want to come back to anticipatory grief a little bit. So I feel like with my father having been dealing with Alzheimer's for a decade now, that I've been anticipating, his death for years and years now. Is that? Excuse me. I know that you also said that anticipatory grief often happens very much near the end of life, like the actual death. But can it go on for extended periods of time?
Oh yeah. It doesn't just happen; it changes at that point. So anticipatory grief, the way I've heard it described that I really like is, it's like being forced to watch a whole movie when you know that the ending is bad. And so when it comes to hospice, the movie is your person dying and the ending is their death. And so you're waiting for this thing to happen. And after a while, when that person is then no longer responsive and you feel like they're suffering again because they're lingering, that's when you start to feel like, I wish this would be over. And that's when anticipatory grief really kicks in at its, highest moment right there, because that's when you're not only grieving the impending loss of your person, you're feeling the guilt over wishing this would be over, basically wishing their life away. So it's really the peak of anticipatory grief. Anticipatory grief can also be considered practice grieving to help you cope with the death after they've died, although that's a whole different kind of grief.
And why do you think that, or why do you say that passing away is maybe not as, what would appropriate be the right word, or
they died or they're dying?
Yeah. Why is passing away not as appropriate as died or dead or dying or whatever?
Well, for one thing, as a healthcare professional, we have to be really clear about what we're communicating to people. Like I said, they're stressed, they're emotional. We don't want to be, you don't want to say something like, we've lost him. What does that mean? Where did he go? We want to be really clear. If it's a family member wanting to talk about that their person passed away, then, that's fine. You're going to say whatever you want to say for yourself to cope. But really, if I said to you, oh, I heard your dad passed away, to me, it's almost like we're done now. We're just going to pass over that conversation. We're going to brush it off. Sorry that happened. If I said to you, I heard your dad died, I am so sorry. I have just given you the opportunity to approach a really difficult subject because I'm not going to shy away from it by using a euphemism. I'm calling it what it is. So it really lets people know that I'm here for you and I'll talk to you about this. I'm ready to go there with you.
Yeah, I like that. And that gets closer to the truth, I think. And it definitely lets people open up, and it lets people talk about that experience and to really face it, to face the fact that their loved one isn't here anymore. But is there even a better, I struggle with the English language a lot in the sense that like the words that we have to describe ourselves and the events that happen within this life are oftentimes, for me, just they don't align with the reality of what's happening. We have so many words that align with a false sense of self as opposed to a true sense of self, that align with a physical form as opposed to a spiritual form that we are. I mean, death is really about what death is it's the separation of the from my perspective anyway, the separation of the spirit from the body. And so it's not really the death, it's the death of the body. The body is no longer connected to the soul, but the soul lives on, or goes somewhere else, or, energy cannot be created or destroyed, scientifically speaking. So it has to go somewhere. So it's not as if that person's energy is dead, and so is there even some other more appropriate way that we could talk about this?
Yeah, I don't know what that would be. And interestingly, Barbara Carnes, who is a hospice pioneer who's written a ton of literature about death and dying, says that there's no such thing as dying. We're born and then we die, and everything in between is life. It's living. And it's true. I mean, it really is. But I don't know of any other way to describe approaching death than dying. That would be universally understood.
Mm-hmm. Yeah, it wouldn't be, and I think it's a part of the problem with just the vocabulary that we have to deal with right now. We lack a complete understanding of our surroundings. We lack an understanding of what happens after death. We don't understand what's before death. Or before life. We think of it as the beginning and the end, and so we're kind of, I think, like confined or binded by or limited by our vocabulary and the way and what we know. And so we have these words that describe what we know, which is really limited, and there's a lot of mysteries. There's a lot of unknowns.
Yeah, and if you think about it too, it doesn't matter what the word is; it still is what it is. And so I think it's important to use the terms that are more generally known worldwide, like died, dying, death, dead, than to use other words, because that it doesn't change what it was. It still is what it is. They're still dying, they're still dead. So calling it something else doesn't change what happened. But people, again, are so afraid to talk about death and dying, they don't even want to use those words.
Yeah. I feel like it creates a misconception about the end of the person's physical form. It creates that image in our mind that this is the end, that the person's dead, that the person's, that their life is gone, and in reality their life is transformed or moved on to somewhere else. And so, I mean, it's like death, dying, dead that's the end. When most people hear that word, that means that's the end. They're no longer, they're not here. And then you have these people, their families suffer, their families, can't cope, they can't accept the fact. But if they viewed this as a transition, as opposed to a hard ending, stopping point because of the word death or the word, dying or whatever it is, then we might be able to speak more accurately about the nature of things,
Yeah, I could see that for people like us who believe that there is something more, but then there are lots of people who don't. They do think dead is the final thing.
Right. So it's a good
and
word.
I don't think passed away is necessarily any better. Like passed away to where, I would almost think like transitioning is good when they're transitioning. Moving on, moved on. Which then again begs the question, where are they moving on to?
Yeah.
But yeah, I don't think there's other terminology that's better for, generally speaking, everybody that could really speak to what it is. I mean, we know that there's death, people die, and it's the end of their body, and then we think there's something beyond that.
Right.
So I don't know.
It's interesting. Yeah, because I think the only people that it wouldn't work for would be atheists, because atheists think that this is a hard ending. But almost every religion thinks that you go somewhere else. You die. You go to heaven. Your spirit goes to heaven. And so even though I guess for me it's not really a belief from the standpoint that I've actually seen an apparition before. I've seen a ghost, and so like I'm more of an experiencer. It's something that I've experienced. You know, I've experienced the afterlife, so I know that there's something after that. And if you talk to other experiencers, people who have had near-death experiences, they all say that they go somewhere else and they see these other things, and that this isn't the end, and they float above their body and they can see everything in the room, and then they, you know, so it's clearly not the end for the experiencers. And so I think for the believers, you have either people who believe that there's something afterwards, or you have people that don't believe that there's something afterwards. One is a positive belief, one is a negative belief, but at the end of the day, they're both beliefs. But then you have the experiencers and the people who have actually had experience with it, either through their own near-death experience or through having experiences with people who have, who have passed, or seeing spirit energy in their lifetime. So they don't have to believe because they've actually experienced these things. And so I think that, but regardless, religion teaches us that there is a next, and it teaches most people who are religion that there is something else. And so it just feels like the only group of people that death really can speak to, for me, feels like atheists. It feels like people where there's a hard ending and there's nothing after that. It feels like it's just more of a transition, you know? I mean, if our mind is stuck in time there's always a beginning and an end to time, and we forget that time is really eternal. I mean, we're in this eternal present moment, but we kind of forget that I think we tend to think of things as having a starting point and an ending point, and we think of death as the ending point. And it's just, I feel like there could be some other way that we could speak about this, and where we could just be, just convey what's actually happening, the reality of what's actually happening, which I think, if you listen to experiencers, is a transition. It's just a transition, you know?
Yeah. And I think there are people who speak in that way, psychic mediums, religious people. But in terms of being a hospice nurse and what's within my scope, it's what it is. It's death. It's the person has clinically died. And beyond what happens there, that's open to your belief and your interpretation. And it's not for me to say something that's going to allude to that, because you might be somebody who doesn't believe in that or have a different belief in that, because you might be a Christian who believes it's heaven. And if I said something that alludes to something other than heaven, like reincarnation, that would be offensive. So as far as the clinical presentation of it and what I communicate, it's got to be death and dying, because that's where we've landed with this. But from the philosophical point of view, then I get exactly what you're saying, that death isn't necessarily the final thing. And so then that's why I say, if a person wants to say that their person went to heaven or they passed away, then that's perfectly fine. But if you're trying to, work in this profession or provide comfort to somebody else, being able to acknowledge that this happened, it's just an easier way to let them know that you're not afraid to talk about that taboo topic of death.
Right. Yeah, it's still the universal language. It's still the words that we're using today, for sure. Yeah. So, interesting. And it makes total sense. I'm not asking you to change the way you talk. I think what you're doing is it's the appropriate language given where we are today in terms of what we understand. But good. Okay. So, what about end of life regrets? What is end of life regret?
I think people would express regrets more if they were speaking to the chaplain. As a nurse, I've picked up things along the way, but most of the things that people regret are going to be what you expect. They wish they wouldn't have worked so much. They wish they would have stayed in better communication with their family. They wish they would have enjoyed food instead of dieting. That kind of thing can come out in conversation with people who are dying. But a lot of time, most of the time, people who are dying are spending less time regretful and more time trying to experience life for as long as they have it left. So they're trying to appreciate the time that they have with their family now rather than mourning the fact that they didn't have more time with their family before.
Okay. Yeah. Good. Okay. But typical regrets are typically
I wouldn't have worked so much, should have retired earlier.
Yeah. Gotcha. What about last words? Is that there's some in terms of like public misconceptions about death? I know that you mentioned that last words, dying last words, are something that people think because it's in movies that it's a typical or common thing, but in reality, it
doesn't happen very often. Because most people who are dying a natural death will go through that dying process where they are transitioning and then getting into the actively dying stage, and we don't know what words they say along the way are their last words. There are cases where somebody will say last words and then die. My dad did that. He said to the nurse, "I'm about ready to hang it up," and then he died. Those were his last words. Who was the one that died? Was it? I don't want to kill somebody off that's not dead yet. Jeff Bezos is still alive, right?
He is, yeah.
Who's the other one? The famous. The Apple guy.
Oh, Steve Jobs.
Steve Jobs. Yeah. Famously said, it's beautiful or something like that. It's beautiful, and then died after that. But most of the time, we don't recognize that somebody is saying their last words until after they've said them. Later on down the road, they've died and we realize that's what they said. But if we're not writing down every single thing they say along the way, we likely don't even remember what they said. So yeah, people don't say last words and then close their eyes and die very often. It does happen. Happened with my dad. Okay. And it's happened with a couple patients that I've had too. But for the most part, they slip into unresponsiveness and then they die after a short time.
And the words with your patients, do you recall what they said?
So I wasn't present when the patient that I'm thinking of had his last words, but he was estranged from his son. And this is a patient that was probably one of the most trying patients I've ever had in my career. Long story about him. It's all in my book. He ended up in a hospice care center and was lingering for quite some time, way past when he should have been still alive, but he was not actively dying. He was still very much transitioning and alive. And his son came to visit him and forgave him for not being more present in his life. And he said, "Thank you. Now I can go." And he closed his eyes and died.
Wow.
Yeah. So that was pretty amazing.
Yeah, for sure. But that's super rare. Mm-hmm. And so typically there's no words. There's
words, but we don't know which ones are the last ones.
Okay.
People talk, and then they're not talking anymore.
Right.
So like I said, unless you've written everything down, you're not going to be able to look back at that and go, "Oh, those were the last words." It's really the ones that we remember as last words are the ones where they say the words and then they die.
Okay.
Which doesn't happen very often.
Mm-hmm. Yeah, Ryan pulled it up, but Steve Jobs was, "Oh, wow, oh, wow,
oh, wow. That's right.
Yeah.
Oh, wow,
times.
Oh, wow.
Yeah.
Yeah.
Yeah, so interesting. So he was clearly seeing something as he was leaving his...
Yeah.
Yeah. So talk to me about the haters. You've got, there's some people who maybe disagree with the work with hospice work. And,
yes.
Yeah. So what's the complaint?
Well, they think that we intentionally kill our patients.
Wow.
And why they think that makes sense, I really don't know, because when our patients die, we don't get paid anymore.
Right.
They think that we make more money the more patients that we have that die faster. Some people have even gone as far as to say we get a bonus when they die, which is absolutely not true. Hospice doesn't make a lot of money, as I explained before. It's a daily rate. Doesn't matter what services we're providing. It's the same for everybody. And when they die, that payment stops. We don't get paid anymore. There's a group called Murdered by Hospice. And these are primarily people who had no decision-making capacity for their person who was on hospice. They were not the legal healthcare representative. Somebody else, either the person who was dying made the decision to go on hospice, or another person that they had legally designated to be their healthcare representative made the decision for them to go on hospice. So these are the people that had no control over their person going on hospice and felt that hospice intentionally killed whoever it was, their mom, their dad, their husband, their wife, whoever. And so they hate hospice in general because of their experience with it. And because I represent hospice, they come after me.
And so they all, how do they group up? Is it like
it's a Facebook group.
Facebook. Okay.
Yeah. Murdered by Hospice Facebook group.
Okay.
Yes.
Okay. And how many members are in this thing?
I do not know how many members.
But it's all people who have had a bad experience with hospice and are
advocating for hospice to be done away with, and trying to educate about how hospice is terrible and you should never put your person on hospice. And some of them are so seemingly delusional, it's like they think that their people would still be alive had they not gone on hospice. And they'll go into the comment section and they'll actually describe situations that I, as a hospice nurse, look at and go, oh, wow, that person is dying and that's appropriate care that they're receiving. And they'll all be saying, no, they shouldn't be doing this. They're going to cause her to death by giving her the morphine. And, it's like, no, that person is dying. The commenter has said she's got end-stage liver failure and now they're giving her whatever medication. That's appropriate care. And then you've got all these yo-yos in the comment section saying, no, it's stealth euthanasia. They're going to kill her off. And, we do palliative sedation in hospice. So terminal agitation is something we haven't really talked about a lot. That can happen during the transition phase when somebody gets extremely agitated. You cannot reason with them. They can't tell you what's wrong. They're completely incoherent. They're trying to get up, restless, sometimes even combative. It's horrible. It's horrible for the person. It's horrible for the family. And we try to medicate them for it with a sedative. And eventually, if we are not able to calm them down enough, we have to do palliative sedation, which is an agreement that's made with the family. We don't just go in there and put people to sleep. We make an informed consent with the family.
You're doing whatever either the patient or the family is telling you to do as it relates to the medication that you're giving.
Right, exactly. Yeah. It's for symptom management. That is what it's for. It's not to end their life. It's intended to sedate them until the time of their natural death. This is what we do so that they can be comfortable and calm until their death. It's a horrible thing for them to experience. So we do this, not very often, but we do this sometimes. And they call it stealth euthanasia, that we are secretly killing these people when really they're dying. And that's why this is happening, this terminal agitation.
They died because they're dying.
Exactly. They died because they're dying. Yeah, that's one of my catchphrases. They didn't die because we gave them morphine. They didn't die because we starved them to death, which is another misconception. We don't starve people. I love giving people the food that they want at the end of their life. I did it for my dad. We gave him a huge plate of every kind of meat there is because my dad was from Texas and he loved that kind of stuff. I love that. But people who are dying are not hungry. Their body is dying. It's going through a dying process, a shutting down process. And it's going to be an energy conservation so that it can complete that process. And as a result of that, they're not hungry anymore because digestion is the most energy consuming process in our body. So they're not hungry. They don't need the nutrition. They don't need the calories. So we say, give people what they want. If that's only just a bite of something that they enjoy, that's fine. But we don't force them to eat. We're not going to coerce them. We don't condone feeding a person to death, like is what happens in nursing homes with dementia patients. They get fed, a more pureed diet until they're on liquids and you're giving them teaspoons of Ensure to keep them alive. We allow their body to dictate what they need. And so, but because we're educating about don't force them to eat, we don't tube feed people, we allow their body to die a natural death, they think that we starve people to death.
So there is an amount of morphine that is lethal.
Sure.
But
there's an amount of Tylenol that's lethal.
Right. But you don't, I mean, but you like, what is that amount and what are you permitted to give people?
So it depends on the person. There's no ceiling dose for morphine, meaning that a person can tolerate as much as they can tolerate. So we can go as high as they need without ending their life as long as they're tolerating it. We start people off on low doses of morphine. People who haven't been on a lot of opioids usually start at about 5 milligrams of morphine. That is less potent than a Percocet. People don't have a problem with Percocet, but they, for some reason, have this huge fear around morphine. Now, if somebody has cancer, they've probably already been on morphine or oxycodone, Oxycontin, Dilaudid. And so we're going to be giving them more medication as their pain increases. They are more opioid tolerant. But somebody who hasn't really been on a lot of opioids, we start them at a very, very small dose, and then we will increase incrementally as they need it. We don't just blast people with an overdose of morphine. You can cause someone's death if you are going to give them, 20 milligrams of morphine or 30 milligrams of morphine when they've never had any. That can cause their death. But as you are ramping up the morphine, as their body adjusts to it, like I said, there's no ceiling dose. We can give as much as they need to have over time as they are getting more accustomed to the doses of morphine.
And how can you tell how much they need?
So they'll either respond to it by having their symptoms relieved or they won't, and then we'll need to give them more. And we're usually keeping track of that too. So we will usually start with an as needed. So it might be 5 milligrams of morphine every 4 hours as needed. And then if that's not working, it might be every 2 hours, and then it might be every 1 hour, and then it might be every 15 minutes, until we're getting their pain managed. And then after we've given a certain amount, it depends on how long the person is expected to live. If it's somebody that's going to live for a while, then we're going to try to convert them to a long-acting morphine. So we look at how much morphine they've had, and we calculate how much that is over 24 hours, and then we would give it to them in a long-acting dose. Or we might start an infusion on them so that they're getting continuous pain relief. We never want to try to chase after pain. We want to get on top of it, and we want to stay on top of it. So oftentimes people will say, they were giving morphine even when she didn't need it anymore. She wasn't in pain anymore. Why wasn't she in pain? Because we were giving her morphine. So we still need to be giving that drug so that they can be continuing to have their symptoms managed.
And the people that are complaining are only the people who do not have the right to decide medically for the person, because if they were the person that had the right to decide, they would just tell you to stop doing it. And then you would stop
Near as I can tell when I read their comments, which isn't very often, just for entertainment once in a while, or to get myself spun up unnecessarily, I will go in their comment section. But yeah, it appears that these people did not have the decision making. People can revoke hospice. You don't have to be on hospice. You can at any time say, I don't want hospice. So if you are the decision maker and your person is no longer decisional and they're on hospice and you think that hospice is trying to kill them, then you can revoke the benefit. You can say, you know what, I don't want this anymore. So when they're saying this, I'm always thinking, well, if you were the decision maker, then why didn't you do that? And if you weren't the decision maker, there's a reason why you weren't the decision maker, because you weren't trusted with that decision. You would have made the wrong choice for your person, causing them to suffer at the end of their life.
And is it, and morphine is given is it given during the transition stage as well?
Whenever they need it.
Whenever they need it.
Yeah. And usually it's usually something that's given more towards the end of life.
Yeah.
But again, with cancer patients, they're coming to us in pain. Opioids already. And so we're just going along with what they're already on and giving them more as they need more, because their pain is going to increase as their cancer gets worse before they die.
And so what does that feel like to you from an emotional standpoint? Like when people are, you're doing your best to do your job and to help someone who's dying and suffering at the end of their life, and you're doing it to the best of your ability, and you're making choices that they want you to make, that the family is instructing you to make, and you're attempting to help this person through their suffering. And then you have someone coming in? What kind of emotions is that creating?
Well, from the outside, it would create this. Help me understand what your concerns are about your person getting these medications so that I can, we can talk more about this. From the inside, it's like, oh my fucking God, not again.
Right.
I didn't want to throttle you. But no, we'll compassionately explain to them that we use morphine safely. We're not worried about addiction. There's no time for that. And we just want to make them be comfortable until the end of their life. And also pointing out what the person looks like to them too. Like, look at them. Do they look comfortable? They look uncomfortable to me. Do you see this? You see this? You see how restless they are? That tells us that they're uncomfortable. Or conversely, yes, we've been giving them morphine and look how peaceful she is. She's comfortable now. Do you remember what she looked like before? Do you remember that she was moaning and every time we turned her, she was stiff? Now she's relaxed. It's working. So we don't want to stop it because we don't want to go backwards and have to try to get on top of that pain again.
Yeah, that's a tough situation. I guess people feel like if something is going wrong and there's a tough situation and they're stressed out because they're losing a loved one, and it's like they probably feel helpless to a certain degree, but ultimately a lot of times people look for someone to blame.
Oh yeah.
Yeah.
I'm definitely their scapegoat.
Yeah.
I mean, I've had people recently, somebody who in a comment said, you gave my mom too much morphine and she died and you're a killer. And I was like, I didn't even know your mom. I don't know you. I didn't know your mom. She wasn't my patient. I don't know what you're talking about, and go after my license. They want to find out where I work. The Facebook comment section is rich for really hateful things. People are pretty hateful on Facebook and will say this, she doesn't deserve to be a nurse. She shouldn't be a nurse. She's making fun of death. She makes fun of her patients, and I'm just their scapegoat. Yeah.
Yeah, I mean, at the end of the day, at some point, you have to be able to, I think, just be able to live your life. I mean, you have a very intense job, of course, and the people that you're working with and dealing with have families and they're stressed, and it's a difficult time for everybody. At the same time, I mean, for you, you've got to be able to find humor, I think, or like just in everyday, kind of like life situations. And if people can't do that, is really, they're kind of torturing themselves to a certain degree, I mean.
Yeah, I mean, there's a lot to be said for levity when it comes to grief. And the reason why I like to use humor and when I'm doing these videos that I make is because I've been with families who use humor for coping, and I've seen how really effective that it is. It's a great coping tool.
Ryan, you use humor for this. Do you have thoughts on this part of the conversation, Ryan?
I do, and thanks for letting me join in, Matt. I was looking through some of the Murdered by Hospice, just posts on the page and everything like that. And, one of the ones that stood out, and I won't show it on the screen, was the story of how their uncle was actively dying, and the nurses asked them to leave the room. And then when they came back in, he had passed. And her complaint was, why would you have us leave the room when he was about to die? And before today's episode, I'd have read that and been like, well, yeah, that's weird. But now listening to you, Penny, talk about the person was trying to hold on. And the moment that they left the room, it probably in that person's mind was like, well, thank goodness, I can move on without that almost, people being in the room. But I think anyone who works in these fields, whether it's first responders, hospice nurses, I mean, you get that gallows humor because when you're in that situation or you're that family member or maybe you're that person, the people that are coming to support you, if they have this look of terror or shock or fear on their face, you're going to be like, well, holy shit, if they're scared, I definitely should be scared. But when you're that provider and you're, not always humorous about it, because you have to pick the person for that. But if you're kind of calm, collected, everything that is happening is normal, that almost brings a sense of relief to that person. Like if the pilot's scared, you should be scared. If the pilot's not scared, I wouldn't worry about it. That kind of sense there. And I've shared my mother was a hospice nurse growing up, and she did have that gallows humor. But at the same time, when it was time to be serious and talk to the family about what was happening, how it was going to happen, and what the plan is, there was no humor. There was only direct answers and direct statements.
Yeah, which is how I am too. And the people that are on Facebook or the other social media platforms who hate on me for making fun of death or dying don't realize that's social media. And they'll say things to me like, I can't believe you treat a patient like that. I'm not at the bedside of a patient. I'm on TikTok. This is not how I am when I am with people for real. I am very compassionate, and I use humor appropriately when I know that that is appropriate to use with this particular patient and or their family. I pick my spots for sure. I'm a professional. So it's insulting for them to say stuff like that to me, but I also just know that haters going to hate, and that is what it is. I know the situation or the story on the Murdered by Hospice Facebook group you're talking about. I saw that as well. And the reason why the nurses would ask somebody to leave their uncle's room is because they're going to do personal care with him and they want to preserve his dignity. There's nothing nefarious that's happening in there. They didn't give him a dose of something to kill him right away when you left the room. They're just trying to protect his dignity. And, that's all there is to it. But you wouldn't be able to go into that comment section and respond to them by saying that because they would shut you down. They're not really wanting to hear that. They're just in their grief so beyond deep, and they're just really enmeshed in their grief. It's become their whole personality to hate. And so I just ignore it most of the time.
Yeah. Yeah. Good for you. I mean, good to understand and get to, understand where other perspectives are coming from, but all you can do is continue to do your job and what the family is paying you to do and to the best of your ability. So, well, good. Well, let's shift gears a little bit, maybe away from the haters and I've got maybe one or two more topics for you. One is euthanasia, or the other word for it would be the acronym is MAID, which is medically
aided dying. Which and to correct you is not the other word for it. It's They're two completely different things.
Right.
So euthanasia is legal in Canada. It's what we do to our pets actually in the U.S. And that is when a medical professional is administering a medication to end the life of a being. And that's how they do their medical aid in dying in Canada. A medical professional, a doctor, will administer the medication. In the U.S., euthanasia is not legal. Medical aid in dying is legal in 10 states and the District of Columbia. And that is very, very strict guidelines for this. You have to have a terminal condition with a no question about it, 6 months of life expectancy or less to be able to qualify. There's a waiting period. You have to be determined to be of sound mind. Nobody else can make the decision for you. You have to make it for yourself. You have to self-administer the medication. Therein lies the difference. A medical professional is not giving you the drug. You are taking it yourself. A family member or a volunteer can mix up the medication and hand it to you, but you have to consume it yourself.
And so that's legal where?
10 states in the District of Columbia.
Okay. I
don't know all the states. I know some of them: Washington, Oregon, California, Montana, Vermont. I can't remember the rest of them.
Okay. And it's a growing list, I guess?
It's trying to be growing. It's in legislation in other states all the time. They're trying to push it through in other states. But it doesn't really, Colorado, Hawaii, Maine, Montana, New Jersey.
And you have to be a citizen of these states, or you can't just travel to these states?
Up until last year, you had to be a resident of the state, but last year, Oregon and Vermont passed laws to where you can come into the state and do it there. you don't have to be a resident, because it's limiting for people who don't live in those states. They have no other resources. And when we don't allow this, people take matters into their own hands. If it's not legal or it's not accessible, and it could be not accessible for a number of reasons, even where it's legal. It might be because the drug for a while cost too much in the state of Washington. It has now come down. They were charging $3,000 for it, so it wasn't accessible to everybody. Or it may not feel accessible to the person because their family members are opposing it, and they want to do it, but their family members are against it. And so they will often take matters into their own hands. And I personally know of patients who have died by suicide in much more horrific and traumatic ways than it would have been had they done medical aid in dying, which is a peaceful death. So I firmly believe it should be federally legal.
Yeah, I do too. And so with euthanasia, it's just the doctor's doing it to you, and that's the only difference. You've got to physically do it yourself with medically aided death.
Right.
And euthanasia is not legal anywhere in the United States, only Canada and...
Oh, I think Switzerland. Yeah.
Right.
And I think maybe some other European countries.
Right.
Yeah.
Interesting. Yeah. Okay. So, but I'm sure it's gaining traction. Yeah. So there's some of the other ones.
Yeah, they have the sarcopod in Switzerland now, which is that pod that people can get into. And I think it puts carbon dioxide. Nitrogen, yes. Yeah.
So what is the concoction that people consume?
I actually don't know.
Okay.
It's a number of drugs that a pharmacist came up with, and they're dissolved into a liquid, and they have to drink them. It's an apparent, or they could put it in a PEG tube, a stomach feeding tube, or a rectal catheter is a new way that they're starting to do it now for people who can't swallow. So previously, if you couldn't swallow or you had a lot of vomiting with your disease, you couldn't do it because you would not be able to consume the drug. But now there are different ways of them being able to self-administer it. And supposedly it burns a lot when you drink it. It's very burning. Oh, look. Okay. Midazolam. So that's a benzodiazepine. That's actually also known as Versed. And that drug is what we use for palliative sedation, midazolam. Propofol is another sedative that's used often. So rocuronium. So that's something that we do not use in hospice ever. But yeah, it's a combination of drugs.
Paralyzes the muscles in the body. So this just freezes their body, and so they can no longer move their lungs anymore.
Yes.
So So if the other first two drugs haven't done it, then that one's going to definitely do it.
And prior to taking this cocktail, and I don't know if this is like what every state uses. I know our state was using a different combination. Like I said, it was $3,000, and then another.
That's Canada. Right.
That's Canada.
Yeah.
Oh, okay. Mm-hmm. So they came up with a different combination of drugs. I'm not sure how widely they publicize it, just because they don't want people maybe making it on their own.
Right.
But typically what happens is first they're going to take a sedative like Valium, Ativan, prior to, like a couple hours prior to doing the end-of-life drugs. And then they have to drink the end-of-life drugs. And I guess it burns a lot when they're drinking it. So that's kind of a bummer. And then the dying process can last anywhere from minutes to hours to a day. So they can actually, it doesn't always kill them right away.
Okay.
Yeah.
Okay. But it's not a painful death.
No.
Yeah.
No.
That would kind of defeat the purpose.
Yeah. Yeah. Exactly.
Okay. Right.
No, it's a peaceful death. It's a peaceful experience for the family to watch. Yeah. It's I haven't personally seen it, but I know many people who have.
Okay.
I've seen it in a documentary that I was able to screen, but yeah, very peaceful way to go, and much better than the alternative if somebody is really convinced that they are going to take matters into their own hands.
Right.
We've had murder-suicides, and in Florida, you had that woman that killed her husband in the hospital. Wasn't that in Florida?
Probably. It sounds like Florida.
Yeah. She was... No, I'm pretty sure it was Florida. She actually was in the news again because she was just recently convicted. And then I think they're giving her some time in jail, but they had a death pact, and she went in with a gun and killed her husband.
Wow.
Yeah.
Okay. I don't think I remember hearing about that one.
Yeah.
But yeah.
I might be wrong that it was in Florida, but I'm pretty sure that it was Florida. Yeah, she
Wife
just got
killed
sentenced.
Dying husband of 53
Oh, she was only,
years.
she was 76. Okay. And I get why she wanted to do that, but I certainly would never condone
Right.
something like that. She was threatening the staff. There was a standoff. It was traumatizing to the nurses and the doctors who worked there.
Wow.
Really horrible. But those are the desperate measures that people will resort to if they don't have an alternative.
Well, good. Yeah. Did we miss anything about about your day job?
I don't think so.
Okay.
I don't know.
Yeah, I don't think so. Feels like
Covered a lot of topics.
Feels like we did. Yeah.
Yeah.
Feels like we it was a really great kind of overview of the whole thing, and I think we went into great detail. So, yeah, it was excellent. Maybe just one or two more topics. You were actually famous prior to becoming TikTok famous.
Infamous.
Yeah. Okay.
For
Infamous.
15 minutes. Yeah.
Right. So what was this story? I just learned about this at lunch today, and I was kind of this was usually people don't get famous twice in the same lifetime for two totally different things. But what was this all about?
Yeah. So my second husband of 10 years and I decided to get divorced, and I needed to have a career, as I was saying before. I decided to go to nursing school, and he was in the military. He was enlisted, so we didn't really qualify for financial aid, nor did we really make enough money to pay for college. And I heard about a woman who had started a website to raise money for her credit card debt. And now, mind you, this was 20, 21, 22 years ago. This is before Facebook. It's before GoFundMe, before any of that. And I thought, well, if she's getting money for doing that, my cause is much nobler. So I started a website to raise money for nursing school, and I called it Help Me Leave My Husband. And it became kind of world known. Got a lot of, at that time, 100,000 hits on a website was a big deal. It was a lot. And so I did a little couple of television shows, Fox National News, a lot of local TV shows, The View, The Other Half. Oh my God.
Is it, there you are? Tell you, Ryan can find anything.
Yes. That's
cool.
yeah. Yeah, I had the recordings on videotape, and I just recently, my son does IT, and he helped me, and I got the cable to hook his VCR up to my computer so I could download these and put them on my TikTok.
Nice.
But yeah, that's me 22 years ago.
That's cool. That's cool. So that was it.
That was it. Yeah, I raised about just a couple $1,000, but it
like
was
2,000.
2,000,
Okay, yep.
2,000, 2,200, 2,300, something like that.
Yep.
I don't even remember. And it became more about the journey instead of the money, because I wasn't just asking people for money. I was blogging about my life. I was blogging about going through school. I had a mailbag where people wrote me letters, and I would answer the nasty ones, like I do answer the nasty TikTok comments, very satirically, and often putting them in their place. And it was funny, and people liked it. And I said, if you like it, send me $1 or $2. I was fully open on page 1 about why I was doing it, that my husband was a great guy, that we just didn't get along anymore. This wasn't about, me wanting to try to stick it to him. And I think what was misleading was that the picture on the website was me with my hands tied behind my back. So it was a view of the backside of me with my hands tied behind my back. So I wasn't showing my face. So people would jump to the conclusion that I was implying that my husband was abusing me, which he wasn't. And I said that right off the go. First of all, my husband is not abusive, but people wouldn't read that. They would just go ahead and start in with the hate. But it kept me accountable, and it kept me focused and on track to be able to accomplish my goal of going through nursing school, just so I could say, see, I did it.
Yeah, it's like a GoFundMe page before GoFundMe.
Yeah,
even
so if you
existed.
use GoFundMe at all, you're welcome.
They got their idea from you.
Yep.
Did they really begin that after?
It was a movement,
Yeah.
It was Karen first, and then me, and then a whole bunch of other people started
Okay.
doing it for all kinds of different reasons.
Sure.
And then after that, and they called it internet panhandling or cyber begging.
Okay.
And then it was still a while though before GoFundMe, because GoFundMe I don't think still came out until maybe, I don't know when it came out. I'm
don't
sure
either.
Ryan will pull it up on
Ryan
the
will tell
screen.
us in a second.
But,
yeah.
because this was in 2000, well, I was 40, so I want to say it was in 2002,
Okay.
around that time, 2001, 2002. And GoFundMe came around in 2010, so it still took a while before GoFundMe. PayPal was alive back then because that's what I used. I had a PayPal link on my website for people to send me $1 or $2.
Okay. Yep. Elon got his cut of that and took it and started Tesla, right? Well, cool. So then, talk to me about your book a little bit as we kind of close out. Where can people find your book?
So it's called Influencing Death, Reframing Dying for Better Living, and it's available wherever books are sold online. There's also an audio version that's on Audible or audiobooks, and I narrated it myself. I started writing stories back when I was first a hospice nurse, and over time so what happened was a few years before I discovered TikTok, I was frustrated with how death was being portrayed on media. I just thought it was, phony and misleading, and I'm passionate about educating and normalizing it. And so I found this website that Amazon had where you could write a screenplay, and they would select screenplays to produce, amateurs. And so I started taking my stories and putting them into this website and making a screenplay out of it. And then shortly after that, they decided they weren't going to do that anymore, so it went away. So I shelved it for a while. And then I got on TikTok, and people kept telling me that I should write a book. I don't just talk about hospice and death and dying on my platforms. I talk about my sober journey, my life, I'm very open about my former drug addiction, my former time in jail, giving up my son, all of that. And I just thought, you know what? Once I had 100,000 followers, I thought maybe I should write a book. People seem to be interested, and it could be inspiring to others. So it's a memoir, and it's really talking about my earlier life and what led me to be a hospice nurse, and juxtaposed with caring for the dying people and how that has impacted me.
What is the biggest way? What's the biggest way that has impacted you personally?
Being a hospice nurse?
Yeah. Dealing with the relationships that you form with the people that are dying, with your patients, and then them actively dying. What is that? How does that impact you?
Well, the biggest impact to me has been now having a belief that there is life after death. That was the biggest for me, which helped to resolve my death anxiety. Just getting to that place of acceptance is probably the second biggest thing, and understanding that accepting that we're all going to die someday is the best way to not be afraid of it, because you can just put it on the shelf and not worry about it anymore. You don't have any control over it. So it's just something that's going to happen, and I prefer now to just live my life and not worry about death and dying. So in a way, working with people who were dying taught me more about living.
Love it. Okay, well, beautiful. Well, where can people follow you?
So I have a website, hospicenursepenny.com, and there are links to wherever you can purchase my book. There are links to all my social media platforms. I'm on Instagram, TikTok, Facebook, and YouTube at Hospice Nurse Penny everywhere. There are also resources, some links to resources for people who have need for resources for hospice. There's an interview guide for if you're looking for a hospice, questions to ask. So yeah, I've got a lot of information on that website.
Perfect. Love it. Okay. Well, this has been a lot of fun. I learned a lot about you, about the process, about hospice, about death and dying, and so it's been fascinating for me. So, and I'm sure the audience will enjoy it as well. So, can't thank you enough for coming down and sharing your knowledge with us.
Thank you so much for the opportunity. I love talking about death.
Yep. Very good. Well, I got a gift for you for your for your journey back.
Oh,
we
gosh, you've done so much for me already, just
Oh.
bringing me down to your beautiful state. Thank you so much.
You're very welcome.
Oh,
Yeah,
cool.
yeah.
Oh, nice.
Yep. Get your own Limitless cup.
Yes.
You get a vase, which I got to show you the vases after.
The power of now. Oh, Eckhart Tolle. Okay.
Yeah, he's phenomenal. He's
you.
changed my life. So I give away one of his 2 books to every guest, and then which I feel like his work actually ties in really well with what you do and with your work. So I hope
He had
you'll
a
enjoy
series
it.
of tapes.
He
too.
did.
A friend of mine has AIDS. He's actually survived AIDS.
Okay.
You know, back in the 80s when nobody survived AIDS is when he got HIV.
Okay.
And then full-blown AIDS, and thought that he would not live to see our 20th reunion, and now our 45th reunion is coming up because of the new drugs that they found. But he was really big on Eckhart Tolle, and he gave me a series of tapes that I was listening to for a while way back when. So,
Nice.
yeah,
Nice.
definitely be interested to read that. Thank
Very
you
good.
so much.
Very good. Absolutely. Well, thank you. I've really enjoyed it.
Yeah, me too.
Yep.
Thanks a lot.
All right.